I'll take a few minutes to introduce our speaker at Grand Rounds this morning. We'd like to welcome Fernando Arevalo to our Zoom meeting. Fernando, we wish you were here in person. It's in this format, but we're so glad to have you all the same. For those who are not familiar with Dr. Arevalo and his work, you will be. If you're interested in retina or uveitis, your career will cross paths probably multiple times with Dr. Arevalo, who's had an impact on many DR specialists around the world. And he's a great colleague and mentor to many in the field. Fernando's career is, to me, a very interesting one. And I don't know, maybe later you can tell us whether you thought things would turn out exactly this way. But he has been around the globe many times and made contributions on multiple continents in multiple arenas within the retina world. Originally, he was trained in Venezuela and completed fellowships in vitreoretinal disease, in uveitis, and in ocular oncology. Fernando worked in South America for the early portion of his career. And then not long ago, what was it, 2011,
yes.
Went to Saudi Arabia and spent several years taking the ophthalmology program to a new level in Riyadh at the King Khalid Hospital, where he was chief of retina. And Fernando, through all of this, continued with lecturing, with publishing. He's written over 300 peer-reviewed articles. And upon completion of his time in Saudi Arabia, he then came to the Johns Hopkins University. He is now the chief of retina at Bayview Medical Center. Very recently, Dr. Arevalo was also president of the Pan American Association of Ophthalmology. And I would imagine that this quarantine is really cramping your travel lifestyle, lecturing all over the world, Fernando. How are you holding up?
Well, I mean, it's very complicated in many ways, but it's a break that I'm enjoying the opportunity to be home and with my family. You know, it's one of the good things of the quarantine. Although I've been bombed with an amazing number of webinars that are coming from different countries around the world, and I mean, it's a pleasure. But it's amazing how everybody's doing webinars right now. There are several every day. It is incredible. But I really miss traveling. And there are many trips that were canceled, and we had everything ready to go. And it's going to be difficult to put things together because most of the things are being canceled for 2021. And there were already the meetings that were going to be happening in 2021. And then after this pandemic, we're going to have financially significant hurdles to overcome, and we're going to need to be working more. So my institution is going to expect that I see more patients. So that's going to be a challenge.
Well, despite all the webinars and everything that's happened with recent disruption, we really appreciate you sharing a couple hours to spend with us this morning. And we look forward to hearing what you have to share with us about diabetic retinopathy.
Thank you. It's my pleasure. I really want to thank you, as well as Prem and Naresh and all the friends. I wish I could be there in person. That was my desire, and was really excited to share with you not only my experience in diabetic retinopathy, but to be able to chat with you in person about so many things. But let's do it virtually, and thanks to Bethany as well for organizing everything. That was really helpful to make this happen. So today we're going to talk about something that I've been working a lot during the last few years on the preoperative intravitreal bevacizumab for tractional retinal detachment secondary to proliferative diabetic retinopathy. So for years we have been researching on this topic, and this is kind of a journey that led to our last publication on a prospective clinical trial on this topic. And we'll get to that at the end of the part of the presentation. Let's see. So these are my financial disclosures, which have no relevance to this presentation. I will be discussing the off-label use of intravitreal bevacizumab. So on the first part of the presentation, I want to talk a little bit about tractional retinal detachments that occur following preoperative intravitreal bevacizumab in severe PDR. You may be familiar with recent publication from the DRCRnet where they gather all the different patients from the clinical trials where intravitreal bevacizumab was intravitreal injections of anti-VEGF was injected for patients with PDR, and they found that there was no a significant number of patients that had or developed a tractional retinal detachment, suggesting that it is safe. However, the patients that we have been studied for with intravitreal bevacizumab injections are a different group of patients than the ones included on the DRC retina network studies, because these are patients that have severe proliferative diabetic retinopathy that is going to have vitrectomy for different reasons, including most of them tractional retinal detachment. So intravitreal bevacizumab, we know that may be useful to treat, for example, early vitreous hemorrhage in PDR. There are some studies that are being performed right now and that we're following patients to see if this is beneficial compared to vitrectomy, and we'll have the results soon. Chen, Park, and Avery were the first to suggest that preoperative intravitreal bevacizumab might be helpful to facilitate vitrectomy in severe PDR cases. And we know that using bevacizumab, several studies have shown that it might reduce the risk of intraoperative bleeding, facilitating the removal of fibrovascular membranes. So, however, our group was the first to report that tractional retinal detachment can occur following intravitreal bevacizumab in patients with severe PDR. We reported 11 patients out of 211 intravitreal injections for an incidence of 5.2% that developed or had the progression of tractional retinal detachment. This is a study published in the British Journal of Ophthalmology a few years ago. And this is, for example, one of the cases. This is from Harry Flynn's practice, where we have this patient with good visual acuity, and there is extensive fibrovascular membranes superior to the vascular arcades along the inferotemporal vascular arcades and nasal. And then after intravitreal bevacizumab, there is a progression, significant progression of the retinal detachment with along the superotemporal and inferotemporal vascular arcades, and especially nasal, with a significant decrease in vision. And this is another patient that had good vision, extensive proretinal fibrosis, And then after intravitreal bevacizumab, a few days later, develops this significant tractional retinal detachment progression and retinal hemorrhage. So the objective of this part of the presentation is to report the development or progression of tractional retinal detachment following intravitreal bevacizumab as an adjuvant to vitrectomy for the management of severe PDR, now in a larger series of patients, but also to look at some possible risk factors for future studies. And we're going to talk about those as well. So this is a retrospective multicenter study of eyes with tractional retinal detachment who underwent intravitreal bevacizumab at a dose of 1.25 milligrams before vitrectomy for the management of PDR, 25 eyes out of 698 intravitreal injections that developed or had progression of tractional retinal detachment were identified. The mean age was 39 years and 54% were male. All patients had had a PRP at least 2 months before intravitreal bevacizumab. All eyes had PDR refractory to PRP. 18 patients had diabetes type 1 with more than 15 years from diagnosis. 7 patients had diabetes type 2, and all patients had uncontrolled diabetes with a hemoglobin A1C with a mean of 9.2%. So patients with very bad control. Inclusion criteria for the use of intravitreal bevacizumab before vitrectomy for the management of PDR in this series included tractional retinal detachment, persistent vitreous hemorrhage, and incomplete neovascular regression even after extensive PRP. So we found that the time from injection to tractional retinal detachment had a mean of 13 days with a wide range. 25 eyes out of 698 intravitreal injections represent an incidence of 3.2% that developed or had a progression of tractional retinal detachment. Here we see the visual acuity results of the 20 eyes that underwent surgery, and the mean baseline best corrected visual acuity was 120. The mean visual acuity at the time of tractional retinal detachment development or progression was counting fingers, and the mean visual acuity after vitrectomy was 2160. So if we look at the visual acuities by subgroups, the final visual acuity after vitrectomy improved significantly on all cases. If we look at the visual acuity after vitrectomy versus baseline, 50% of eyes improved, and 25% of eyes lost 2 or more ETDRS lines of visual acuity compared to baseline, but it still improved after vitrectomy. These are a couple of selected cases that I wanted to share with you. This is a 22-year-old woman with poorly controlled diabetes type 1 since age 6, bilateral PDR, PRP in her right eye. This is the right eye here in the photograph. Best corrected visual acuity was 20/200. There is extensive neovascularization on the disc, and diabetic retinopathy is seen along the vascular arcades and in the macular area with leakage of fluorescein angiogram. An injection of 1.25 milligrams of bevacizumab was given, and 4 days later, there was sudden visual loss to counting fingers with a dense vitreous hemorrhage and partial tractional retinal detachment. After vitrectomy, the patient improved to 20/50. This is another example, a patient that had extensive neovascularization on the disc and along the vascular arcades, and this is seen better on the fluorescein angiogram. You see the neovascularization on the disc along the vascular arcades and temporal to the fovea. And then after intravitreal bevacizumab, a few days later, you can have or see the extensive progression or development of a tractional retinal detachment along the vascular arcades and temporal to the fovea. The fluorescein angiogram demonstrates that there is resolution or regression of the neovascularization on the disc and elsewhere with areas of non-perfusion. So The development or progression of tractional retinal detachment in PDR following intravitreal bevacizumab could have happened by natural history or rapid neovascular involution with accelerated fibrosis and posterior hiatal contraction as a response to decreased levels of VEGF. What I think that happens is that there is a level that is balanced between VEGF and cytokines that cause contraction in the vitreous cavity. And when you inject anti-VEGF therapy, the VEGF levels decrease and the relative levels of those cytokines that cause contraction increase, and that creates the crunch effect on some cases. The short time between the injection and tractional retinal detachment suggests a cause-effect relationship. More than 81% of the tractional retinal detachments develop or progress 5 days or more after the injection. That's why we recommend that the surgery should be performed 4 days after the injection. It could be less than that, it could be 2 days. There is some effect of the anti-VEGF even 1 day after injecting it. So in cases at risk for progression of tractional retinal detachment that might involve the central macular region, timely surgery should be anticipated. Avery has reported that diabetic eyes may be very sensitive to intravitreal bevacizumab. Therefore, the use of lower doses is prudent in eyes with pre-existing significant traction. You could even inject half of the dose of 1.25 milligrams and still have an effect in diabetic eyes. Advantages of intravitreal bevacizumab is that it reduces the risk of intrahepatic bleeding, facilitating the removal of fibrovascular membranes. There is better visibility during surgery, which leads to the less likelihood to create an iatrogenic retinal break. Chances of postoperative complications such as rebleeding or fibrinoid syndrome can be decreased. All these advantages may allow us to save more eyes utilizing preoperative intravitreal bevacizumab, regardless of increased traction on some severe PDR cases. In summary, for this part of the presentation, tractional retinal detachment in PDR may occur or progress after intravitreal bevacizumab used as an adjuvant to vitrectomy. Surgery should be performed 4 days after intravitreal bevacizumab. Remember that even though it may occur on a small number of patients, surgery will improve visual acuity on those cases. So I think it's still beneficial. Most patients had poorly controlled diabetes associated with elevated hemoglobin A1C, insulin administration, PDR refractory to PRP, and longer time between intravitreal bevacizumab and vitrectomy. So that led to our this study on risk factors. Risk factors now for tractional retinal detachment following preoperative intravitreal bevacizumab in severe PDR. So the objective of this part of the presentation or this study was to determine the risk factors for the development or progression of tractional retinal detachment after intravitreal bevacizumab used as an adjuvant to vitrectomy for the management of severe PDR. So the clinical parameters of these patients previously identified as potential risk factors for tractional retinal detachment were obtained and analyzed and compared to the clinical characteristics of those patients that did not develop a tractional retinal detachment after intravitreal bevacizumab for PDR. Remember that we had about 700 eyes that we injected, and then 25 of those eyes developed a tractional retinal detachment. So we compared the characteristics of those groups, including between those parameters, elevated hemoglobin A1C, insulin administration, PDR refractory to PRP, bevacizumab dose, and longer time between intravitreal bevacizumab and vitrectomy. A statistical analysis was performed using a multivariate and bivariate analysis. And we found that the risk factors for tractional retinal detachment after intravitreal bevacizumab identified in the study included more than 15 years from diagnosis of diabetes, more than 13 days from injection to vitrectomy, and the use of a higher dose of bevacizumab, the dose of 2.5 milligrams, which was used years ago in some studies, including DRCR-NET studies. These are the risk factors that we analyzed, and the three here on the circle that demonstrated to turn out to be associated to the development of tractional retinal detachment. This is an example of one of our cases. This is before vitrectomy with the significant presence of fibrovascular tissue along the vascular arcades, and you can see retinal fibrosis. 10 days after intravitreal bevacizumab, there is a significant progression of the retinal detachment, nasal, and especially along the inferotemporal arcade, vascular arcade, as you can see here. And then after vitrectomy, there is a retachment of the retina in this particular case with silicone oil. In summary, based on this multivariate and bivariate analysis, risk factors for tractional retinal detachment after intravitreal bevacizumab in PDR are time from diagnosis of diabetes of more than 50 years, time interval from intravitreal bevacizumab to vitrectomy of more than 13 days, and the use of a higher dose of intravitreal bevacizumab. Prompt surgery should be performed after intravitreal bevacizumab injection. So again, we recommend that surgery should be performed 4 days or less after the injection, and the use of a lower dose, the lower dose is recommended, in this case, 1.25 milligrams. And this was published in ophthalmology. So let's turn to a surgical technique. Perfluorocarbon liquid used in minimally invasive vitreoretinal surgery. For this particular study, you used 23 gauge transconjunctival sutureless vitrectomy, although nowadays I use more 25 and 27, and combined with preoperative intravitreal bevacizumab for membrane dissection in diabetic tractional retinal detachment. So we know that first-line vitrectomy is established and successful for the treatment for complications of PDR. It is required within 1 year in up to 10% of patients presenting with PDR. The commonest indication for surgery is non-clearing vitreous hemorrhage and tractional retinal detachment, and postoperatively, unfortunately, still postoperative vitreous hemorrhage with or without tractional retinal detachment can occur in a significant number of patients, about 20 to 30% of the cases, according to some series. In the past, delamination, segmentation, and bimanual surgical techniques have represented advances in the treatment of severe PDR and other vitreoretinal conditions. And bloc dissection was described by Abrams and Williams in 1987 for diabetic tractional retinal detachment as a technique in which fibrovascular diabetic membranes and the posterior hyaloid are separated from the retina as a single unit. And you can see that in these drawings from Michael's Retinal Detachment, which I think is one of the greatest books that were published out there on retinal detachment techniques. However, it's very much outdated nowadays, but it shows very nice techniques in general. And you can see here how the anterior posterior traction helped with aspiration of preretinal hemorrhage, as well as the delamination of these membranes, and it allowed for the en bloc dissection of the membranes and the vitreous, again, in what was called en bloc dissection. And then vitrectomy could be completed, and fluorescence change could be performed with endolaser to finish the case with gas or silicone oil. Viscodissection was described by Stankula and Tornquist as a surgical dissection technique that facilitates removal of epiretinal membranes by injecting viscoelastic between the retina and the epiretinal tissue. Chang introduced perfluorocarbon liquid as an intraoperative tool in vitreoretinal surgery. After that, it has been and gained widely acceptance for the management of retinal detachment with PDR, TRDs, giant retinal tears, dislocated crystalline lens, and IOLs, ocular trauma, intraocular foreign bodies, and control of intraoperative hemorrhage. So years ago, I described this technique in bloc perfluorodissection in vitreoretinal surgery, which I used to separate the membranes from the retina and the posterior hyaloid with perfluorocarbon in a very atraumatic way. And it was very useful for those membranes that grow on uveitis cases and to perform a complete atraumatic dissection and detachment of the posterior hyaloid in endophthalmitis cases. Remember that in endophthalmitis, for example, it's difficult to perform a complete vitrectomy. The classical teaching is that you perform a limited vitrectomy because if you try to detach, for example, the posterior hyaloid, the retina is very friable because of inflammation and you can create a tear. However, with this technique, you can inject perfluorocarbon and separate the membranes and the posterior hyaloid from the retina in a very atraumatic way and perform a very complete vitrectomy, which helps in many endophthalmitis cases to have a better result from the visual acuity point of view and also control of the infection. I also wanted to use it and see what happened on tractional retinal detachment in PDR, and we published that as well. And we combined it with a small gauge instrumentation. We know that the Juan reported that and introduced that with 25 gauge in 2002. Klaus Eckert developed 23 gauge instrumentation, and nowadays the most popular techniques include 27, 25, and 23 gauge. So what we wanted to do is then combine all these techniques in a technique now called en bloc perfluorodissection and combine it with preoperative intravitreal bevacizumab to dissect these membranes in diabetics with utilizing minimally invasive vitreoretinal surgery, in this case 23 gauge. And we included here patients with tractional retinal detachment in severe PDR, macular involvement or impending macular involvement with or without vitreous hemorrhage. And bloc perfluorodissection was performed in 114 eyes during vitrectomy for TRD, and the mean patient's age was 42 years. The mean surgical time was 50 minutes. Patients were followed for a mean of 24 months. Each patient underwent measurement of visual acuity with ETDRS charts. Patients were examined at day 1, week 1, week 2, and 1 month after vitrectomy, and then every 3 months thereafter. An increase or decrease of visual acuity was considered to occur if there was a change of 2 or more lines of the TDRS lines, and patients were included in this consecutive series if there was a minimum of 12 months of follow-up. The main outcome measures included changes in best-corrected visual acuity and retinal reattachment. So let me show you the technique. Here you can see that we open a small hole in the mid-periphery of the posterior hyaloid, and then perfluorocarbon is injected between the retina and the posterior hyaloid, separating the posterior hyaloid and the membranes, injecting perfluorocarbon to complete that. And then vitrectomy can be completed, endolaser can be applied on the perfluorocarbon, or you can aspirate the perfluorocarbon depending on the status of the retina. An air fluid exchange can be performed, and endolaser can be applied. So let me show you a case. This is a patient that had a significant vitreous hemorrhage. So I performed ultrasound before surgery to see the areas where the posterior hyaloid was more separated from the retina and where the areas of significant adhesion or membranes were located. So here we open the hole in the posterior hyaloid and we inject perfluorocarbon to start separating the membranes. And the membranes were separated partially with perfluorocarbon and then I'm using the cutter to continue separating the membranes. So the idea with this is not, as shown in the cartoon, to separate everything with perfluorocarbon, although that can be obtained in patients with uveitis. But in tractional retinal detachments, many of the membranes are too adherent to the retina. So we use it as part of the armamentarium. I use it as one more tool, one more instrument. I also use, of course, the cutter, as you can see here. I use pick, forceps, scissors, whatever is necessary. I like to use a chandelier to have the opportunity to use bimanual techniques as needed. And again, it's only part of the armamentarium. You see that here, I was aspirating part of the perfluorocarbon because I didn't feel that I needed it anymore once the dissection was performed, and allowed for, because I inject perfluorocarbon to the periphery of the retina, it dissects the posterior hyaloid to the periphery, so it's easier to get that separation to the periphery of the posterior hyaloid, and then vitrectomy is easier to be shaped in the periphery. Again, the use of a chandelier allows for scleral depression myself. I prefer to do that rather than have the assistant do it. And then I can do a good vitrectomy in the periphery. Endolaser can be applied once you have eliminated all the membranes. And as you can see here, no need to have the perfluorocarbon anymore in the eye in this particular case. And then an air fluid exchange is performed to finish the case with gas. So en bloc perfluorodissection was performed in this series using a mean volume of 4 cc, so you don't need to use a lot. This is very different than vitrectomy using perfluorocarbon infusion, as was described by Hugo Quiroz Mercado years ago. This is just a little bit of perfluorocarbon, just one vial is enough to perform this surgery. None of the patients had ocular hypertension or undue inflammation. Anatomic success was obtained on all cases with significant improvement in visual acuity, more than 2 lines in 70% of the cases. In the final visual acuity was 20/50 or better in 25% of cases, between 20/60 and 2400 in 47%, and worse than 2400 in 28%. Again, that depended on the chronicity of the cases. Complications, of course, do occur. And we had one case with thesis bulbi, iatrogenic retinal breaks in 8 eyes, vitreous hemorrhage requiring another procedure in 8 eyes. Perfluorocarbon liquid came under the retina in 2 eyes, and cataract in 26% of eyes. The subretinal perfluorocarbon is a severe complication, but what I did for those cases was to continue peeling all the epiretinal membranes, and once I release all the traction, it's not difficult to drain the perfluorocarbon from the subretinal space by opening a retinotomy or draining through a tear if one is present. So it's not a big complication as long as you release all the traction from the retina. Let's see. This is another video that shows now without vitreous hemorrhage. You can see a little better what I'm doing here. The hole is open at the mid-periphery of the posterior hyaloid, and then perfluorocarbon is injected. Some of it gets into the vitreous cavity because there is a lot of adherence of the membranes between the retina, the posterior hyaloid. There is not a lot of, it doesn't give a lot, and the perfluorocarbon cannot separate the membranes as well, but it does help significantly, and then I use the other instruments to complete the lamination of the membranes, as you can see here, again, using a chandelier to use by manual techniques, and using the cutter a lot, but I also use the forceps and picks to delaminate the membranes up to the periphery. Another advantage of using perfluorocarbon is that it keeps the retina attached in the back of the eye and controls the bleeding much better, so decreasing the need for endodiathermy. And then because the retina is flattened with perfluorocarbon, endolaser can be applied. These retinas are very edematous because they have retinal detachment, and endolaser is applied better on the perfluorocarbon, and then an air fluid exchange can be performed to finish with gas. So in summary, bloc perfluorodissection seems to have advantages, including retinal stability at the time of vitreous removal, better visualization of vitreous and intraocular structures, rapid retinal reattachment, less blood in the vitreous cavity, subretinal resolution, subretinal fluid resolution, blood confinement, and easier dissection of membranes using perfluorocarbon in limited amounts and a simple technique. Experienced surgeons, of course, can manage complex retinal detachments using either viscodissection or conventional pick and scissors dissection and by manual techniques. And I'm a very big fan of bimanual techniques, and you will see a couple of videos later. Surgical time is decreased with this technique, including a small gauge vitrectomy and the use of intravitreal bevacizumab preoperatively in PDR. In our study, the prevalence of postoperative vitreous hemorrhage was lower, about 7% that reported in other studies from 20 to 30%, which can be explained by the use of intravitreal bevacizumab preoperatively 4 days before vitrectomy. And this was published as well. So then, based on our studies that were retrospective over the years, we decided, I think it's time to perform a prospective study. And we designed this prospective randomized clinical trial that we performed with the help of the Pan American Collaborative Retina Study Group network in Latin America. This is a on-preoperative intravitreal bevacizumab for tractional retinal detachment secondary to PDR. So a meta-analysis supports the use of preoperative bevacizumab in diabetic vitrectomies. However, I already mentioned that we have previously reported that tractional retinal detachment may occur or progress shortly following the administration of intravitreal bevacizumab in patients with severe PDR. In addition, other studies have demonstrated the same, that in patients who have extensive preretinal fibrosis, tractional retinal detachment may occur. For those reasons, there is no consensus in the retina community regarding the usefulness and benefit of intravitreal bevacizumab as an adjuvant to vitrectomy in tractional retinal detachment in PDR. In our practice of 18 vitreoretinal surgeons, not everybody uses intravitreal bevacizumab before diabetic vitrectomy, and I have asked some people around in the country, and again, there is no consensus. For example, in Bascom Palmer, many people don't use it. So the objective of this study, and we wanted to hopefully put the issue to rest, is to evaluate the effectiveness and safety of an intravitreal injection of 1.25 milligrams of bevacizumab as a preoperative adjunct to a small gauge postplanar vitrectomy in eyes with tractional retinal detachment secondary to PDR. So again, this was a prospective multicenter randomized clinical trial conducted by the Pan American Collaborative Retina Study Group. 9 countries and 13 clinical sites in Latin America, the US, Saudi Arabia, and Spain, and 224 patients participated. So the patients' eligibility criteria included patients that were 18 years old or older with PDR and tractional retinal detachment threatening or involving the fovea with or without a rhegmatogenous component and with or without vitreous hemorrhage. In terms of exclusion criteria, we excluded patients with a tractional retinal detachment due to causes other than diabetes, and we excluded patients with a history of major ocular surgery within prior 4 months of randomization. Patients were enrolled and randomized with a 1-to-1 ratio to small gauge prosplenic vitrectomy plus sham, the control arm, or small gauge prosplenic vitrectomy plus intravitreal bevacizumab, the study arm, 3 to 5 days before surgery. Here you can see that we enrolled 224 eyes. 10 patients were not eligible according to our inclusion and exclusion criteria. We ended up enrolling and randomizing 102 patients in the study group and 112 patients in the control group. All patients were accounted for at 1 year of follow-up. So the primary outcome comparisons included intraoperative bleeding and postoperative vitreous hemorrhage. Secondary outcome comparisons included the number of endodiathermy applications and intraoperative breaks. Patients were examined at day 1, week 2, month 1, 3, 6, and 12. Patients underwent a complete ophthalmic examination at every visit and imaging. And this is an example of the kind of patients that were included in this trial. You can see that there is a fluoride tractional retinal detachment. We perform a small gauge prosplenic vitrectomy with a 360-degree peripheral vitrectomy first to reduce the anterior posterior traction. The vitreous is sustained with triamcinolone. Use a chandelier to be able to perform by manual techniques. As you can see here, when I see membranes like this that are very large and adherent to the retina, I prefer to use by manual techniques. I use a forceps and a pick to delaminate and separate these membranes from the retina. I was masked as to if these patients were injected with intravitreal bevacizumab or sham. So I don't know, but there is still some bleeding in these cases, even if you have intravitreal bevacizumab. We can see here that I'm using the cutter to trim the membranes. I use the pick to try to delaminate the membranes to the periphery. And then what I find very useful is to, even once all the membranes are peeled, I like to use perfluorocarbon to flatten the retina for the reason that when you have a large tractional retinal detachment, the retina is very edematous because it's been detached for a long time. And then by using perfluorocarbon, you confine the areas that are bleeding. So I need to perform less endodiathermy. And also endolaser can be more easily applied to those areas that are thickened in the retina. So you can see that here we perform endolaser. Again, because I use a chandelier, then I can scleral depress myself and that is easier. And I find if there is a break, like in this situation, I can treat it and I can complete the endolaser in 360 degrees in the periphery with the scleral depression, as you can see here. Air fluid exchange to finish the case with gas in most of the cases, and silicone oil if the case is if the patient is monocular or needs to travel by plane. So we found that 80% of our patients were operated on with 23 gauge instrumentation for the study, although again, I do most of my cases with 27 and 25 gauge instrumentation on a hybrid approach nowadays. This is the baseline characteristics table that demonstrates there was no significant difference between patients between both groups. For example, patients in terms of systemic glycemic control, where all patients were controlled with combined therapy. Hemoglobin A1C was about 8.5 and 8.9 respectively, no significant difference there. About 80% of the patients were had a previous history of a PRP, and about a little over 70% were phakic. So we found that in terms of intraoperative complications, in the control group, there was more intraoperative bleeding. So the number of patients that had intraoperative bleeding was higher in the control group than in the study group. This difference was statistically significant, including intraoperative bleeding grade 2, which is the one that needs endothermy. The use of endothermy applications was necessary, again, in a higher number of patients in the control group compared to the study group, a difference that was statistically significant. So definitely patients bled less with intravitreal bevacizumab. Iatrogenic retinal breaks were found in a higher number of patients in the control group than in the study group. And again, confirming that possibly this is because you have better visibility because of less bleeding. This difference was statistically significant. Now, in terms of visual acuity, there was no significant difference in terms of significant improvement of more than 2 lines, although there was a trend toward better visual acuity in the study group compared to the control group. We can see that trend here, but again, was not significant. We wanted to see if the patients divided by which ones, the ones that had vitreous hemorrhage at baseline compared to the ones that didn't have vitreous hemorrhage at baseline, if that made a difference, but it didn't. In terms of reattachment rate in the study group, the reattachment rate was higher than in the control group, but again, this difference was not statistically significant. The adverse events, the only adverse event related to intravitreal bevacizumab injection was that similar to our retrospective studies, about 2.9% of patients had progression of the tractional retinal detachment 3 days after the injection. However, again, similar to what we had seen in our retrospective studies, visual acuity improved after vitrectomy on those cases. And this complication obviously was not seen in the control group. So let's see another case. This is a vitrectomy with 25 gauge instrumentation. And this is another case that I did with bimanual techniques because there was a very adherent plaque in the posterior pole. Again, using chandelier to be able to do this. You could do bimanual techniques by utilizing a lighted pick and a forceps, but I like to put in a chandelier and utilize different instruments to perform these bimanual maneuvers. You can see here how it's a very dedicated and time-consuming surgery, but it is worthwhile to take the time to separate these membranes very slowly and have a good surgical result. We can see here that even though, again, this membrane looks with reduction of the vascular component, may be injected with bevacizumab, but again, I was masked about which patients were injected with bevacizumab or were in the sham group. But there is, the video looks a little blurry because of bleeding in the vitreous cavity, but still the surgery can be performed. We're trimming the membranes. I like to trim the membranes and then grasp it again with the forceps and use the pick to continue peeling the membrane to the periphery of the membrane, and very slowly using the blunt part of the pick against the membrane, you can separate them in a very atraumatic way. And you can see there is still some bleeding, but it's not a lot. Again, I think that's maybe this is a patient that had preoperative intravitreal bevacizumab, and once we, with the forceps, can separate the membrane, then the cutter finishes the job, as you can see here. And then, even though everything is being separated, I like to use again perfluorocarbon to control the bleeding and reduce the need for endothermy. And again, like I said before, it facilitates the take of the endolaser by flattening the retina better. That is very thickened because of the tractional retinal detachment. So endolaser can be applied in this fashion. Sometimes what I like to do, if I see that the retina is completely attached, is to aspirate the perfluorocarbon before completing the laser or the air fluid exchange, just to avoid aspirating perfluorocarbon under air and decreasing the risk of leaving some perfluorocarbon in the back of the eye, although we all do those perfluorocarbon air exchange and don't leave any perfluorocarbon in the eye. But if I can aspirate it, I do it just to, so that I don't have to worry about it when I do the air fluid exchange. So endolaser is finished, and air fluid exchange is applied, performed, and then gas is utilized again in this case. This is a 27-year-old male with a visual acuity of 2400. You can see the significant tractional retinal detachment, nasal and along the vascular arcades. And bevacizumab is injected, and you can see a significant reduction on the photograph to the right, significant reduction here of the vascular component of the membrane. And then after surgery with silicone oil, you can see the retina is reattached with improvement in visual acuity. This is a 54-year-old male with a visual acuity of 2800. You can see the fibrovascular tractional retinal detachment. And after intravitreal bevacizumab, you can see the reduction on the vascular component here. And then after surgery, with gas, 1 year later, you can see the with improvement in visual acuity. And this is a 47-year-old male with a visual acuity of 2400 that has significant fibrovascular membranes in the left eye, and you can see the significant reduction after intravitreal bevacizumab a few days later, and after surgery with gas. You can see the reattachment of the retina with improvement in visual acuity. So the strength of our study is that it is a prospective randomized clinical trial. However, its multicentric nature is also a limitation, as multiple surgeons from several centers participated with a non-standardized surgical technique, including all available gauges of minimally invasive vitreoretinal surgery. Basically, every surgeon performed the surgical technique with which they felt more comfortable. So that is a limitation. In summary, this randomized study demonstrates that preoperative intravitreal injection of bevacizumab might be helpful to facilitate vitrectomy in cases of tractional retinal detachment secondary to advanced PDR. Preoperative intravitreal bevacizumab seems to reduce intraoperative bleeding, improving surgical field visualization, and reducing intraoperative and postoperative complications, including iatrogenic retinal breaks and postoperative hemorrhage. It's possible that with a larger number of patients, the trends towards better visual acuity could be demonstrated to be significant, but in our study, it was not significant. Let's see. This is being published in American Journal of Ophthalmology if you want to look at more details about the study. And I would like to thank the Pan American Collaborative Retina Study Group, 20 centers from 13 countries in Latin America and Spain for presenting. And again, I'd like to thank you all for the opportunity to give this lecture virtually. Sorry that I couldn't be there in person, but I think this doesn't count as a grand rounds officially. You have to invite me again to go to Colorado so that I can see you all and share experiences in person and have some dinner with you. Thank you.
Thanks very much, Fernando. One of the problems with doing a Zoom call is that you can't hear everyone clapping, but I'm sure if we unmuted all of them, they would be. This is several decades of tremendous work. And I have to think of the hundreds or even thousands of people whose vision has been saved or improved because of the contributions that you've made here. And I'd congratulate you for making a prospective study out of it to really try to definitively answer some of the questions around management of these TRDs from diabetic retinopathy. I do have a question for you. One of the things that we have done is to shorten the time between injection of bevacizumab and the initiation of the vitrectomy, particularly due to the fact that many of these diabetic patients can become sick and can wind up having their surgery canceled or postponed, which can lead to a long delay between the time of pre-op injection, if it's done in clinic, and the time of surgery. And so for the last 5 years or so, I've exclusively used a method of injecting the patient in the preoperative area before the commencement of surgery, but once we know for sure that we'll be able to get them into the operating room. The primary goal being control of hemostasis, but intervention before much of the contraction occurs. Thankfully, there have not been any that have shown progression or contraction over a very short period of time, and management of intraoperative hemorrhage seems to be easier. What are your thoughts on same-day injection of Avastin before beginning surgery?
So I haven't done it on the same day. I'm happy you're doing it and that you have a good experience. That will encourage me. So I'm so happy I'm doing this because I'm learning so much from you guys. I would definitely, on patients that did not get the injection in clinic preoperatively, now that I hear your experience, give it preoperatively before the surgery and see, you know, how it works. I think that's really interesting. The closest to surgery that I have given it is 1 day before. And it works. I feel that the amount of reduction on the vascular component of the membranes is not as strong as if I can inject let's say 3 days before, but it does a job, and it does reduce the bleeding during surgery. So I think it's useful if, let's say, a patient didn't get the injection and I give it the day before, then, I think it does help. But I'm happy to hear that doing it the same day of the surgery it's been successful. So I think that's wonderful. Yeah. Any other questions?
I have a question, Fernando. This is Jesse Smith, one of the retina faculty here. Thank you so much for sharing your work.
Absolutely.
There have been some reports, but not very well controlled studies on the efficacy of intraoperative bevacizumab in controlling the incidence of postoperative vitreous hemorrhage, postoperative macular edema, and sequelae of that sort. Do you have any experience with that or comments on intraoperative Avastin?
Yes, I do it on patients that didn't have preoperative Avastin, patients that I do surgery and have some macular edema, or that I perform a vitrectomy for vitreous hemorrhage and I want to reduce the chances of postoperative vitreous hemorrhage. And it does, according to the studies and my experience, reduce the chances of postoperative vitreous hemorrhage. So I think is useful. Especially for vitreous hemorrhage, for diabetic macular edema, I use it, but I'm less worried about those cases because I think that for diabetic macular edema, if you have it on a vitrectomized eyes, the studies have shown that anti-VEGF therapy will work even in vitrectomized eyes, as steroids would work in vitrectomized eyes. You just need to give probably more frequent injections than on a patient that is not vitrectomized, but still they will work. But thank you for the question.
Hi, Dr. Arevalo. This is Rachel. I'm one of the Retina Fellows here. Thank you so much for that fantastic and very educational lecture. I just had a couple questions on the how you use PFO in the surgeries for TRDs. You had mentioned that in your case series, there were 2 cases of subretinal PFO. Did these occur in patients who had like a combined TRD-RD with already an existing posterior break? Or I guess the question would be, do you have any additional hesitance in using this technique in patients where you know there is a posterior break, or is this not a problem because it can be fixed afterwards?
That's a very good question. Yes, I have a concern if there is a combined regmatogenous and tractional retinal detachment, because the presence of a tear, if you have membranes, then the perfluorocarbon will go under the retina. So the cases that I had were cases where a tear developed while I was injecting perfluorocarbon, and then because the membranes had not been peeled completely yet, because of the traction and the new tear, the perfluorocarbon went under the retina. So if I know there is a combined component, then I don't use perfluorocarbon on those cases. So I think this is an important point that you raised. Thank you for doing that.
Great, thank you so much. One of the other questions I had was that you had mentioned that one of the ways that you liked using PFO in these cases was that it had a flattening effect on the edematous retina, and that was made it easier for laser to get some uptake in those areas. Do you feel like if we lasered under like air after an air fluid exchange, that would achieve a similar level of effect, or PFO just works much better?
I think that air can have a similar effect. I usually laser under air. I mean, many times I do it on probably on a different, maybe if the case is easier and I don't need to use perfluorocarbon, I many times do it under air. And I think that, yes, it is definitely an option. And again, like I mentioned, I use perfluorocarbon as part of the armamentarium. And I could use it at the beginning of the procedure to separate as many membranes that I can with perfluorocarbon, and then I can aspirate it and continue with the other instrumentation. And then once I peel all the membranes, I can do an air fluid exchange and maybe do the laser on their air. So you can use it in many different ways. Again, everybody does things in different ways, and I think that's fine. I think that's perfectly fine. Yeah.
Great, thank you so much. I have one last question.
Thank you. Oh yeah, sure.
You had mentioned earlier when talking about intravitreal bevacizumab that using a reduced dose of bevacizumab may be better for patients who you're concerned are at risk for crunch. Are you using like a decreased dose of Avastin even in your practice when you're injecting these patients like 3 to 5 days prior, or just using the full dose?
I use the full dose, 1.25 milligrams if I know I'm gonna go to surgery. I'm suggesting half the dose of that. If you are injecting, if you feel you need to inject a patient that you see some fibrosis, but you're not gonna take that patient to surgery. Let's say the fibrosis is extrafoveal and you have a fovea that is stable and you don't think it is threatened, and you know those cases can have a stable vision for a long time. So if I feel that I need to inject because there is extensive neovascularization, maybe not responding to laser, that is a whole different talk. About PDR and treatment with laser and anti-VEGF therapy. I believe in a combined paradigm of laser and anti-VEGF. And then if I'm gonna use anti-VEGF and there is a little bit of traction, I would like to use a lower dose. That's where I use it.
Great, thank you so much. I'm finding that is particularly a useful thought. In these times, we have a lot of patients who we normally would take to the operating room, but now their surgeries have been slightly delayed due to the coronavirus situation. So I think I'll be trying the lower dose of bevacizumab in these patients.
Wonderful.
Thank you.
Absolutely, absolutely. Feel free to email me if you have any questions. I'm sure Bren Scott can give you my email address if you have any doubts. I'd be happy to help in any possible way. And this is for anyone who has any questions. So,
Fernando, could you hear me right now, Fernando?
Yes, I can.
Hi.
Oh, Naresh. Oh, you were there.
I've been here the whole time. I've learned a lot.
Oh, I thought you were sleeping. I'm just teasing you.
Yeah, no, we really enjoyed your talk. It was really phenomenal. And we'd love to have you here so we could give you a big hug and see you for real in the future here. One of the, I know we're running out of time, and I just wanted to thank you. I also just had one final question, you know, and I want to make sure that the residents, fellows, everybody else understands that this preoperative technique is, you know, it obviously is really amazing and phenomenal. That, you know, that long term, and we talked about intraoperative Avastin at the end of the case. You know, and if you saw Dr. Arevalo's work in terms of his peripheral laser photocoagulation, his extensive laser photocoagulation, there's really no substitute for that in terms of recurrent bleeding. We've seen some studies with small gauge surgery with very high rates of postoperative bleeding, and I would guess that's something that Dr. Arevalo doesn't see that much, and I'd like him to comment on that, and sort of the risks of using Avastin as a therapy to prevent recurrent bleeding versus laser photocoagulation. Could you comment on that, Fernando?
Well, I think both are important. Again, like I mentioned, I'm an advocate of a combined paradigm. And if we have to take the patients that, if we're talking about the patients that we take to the OR and we perform a vitrectomy, it is key to perform a good pan-retinal photocoagulation during surgery. And even, I mean, we see PRPs all the time in the clinic that are very shy, where the periphery, far periphery is not treated. And that's a problem. That's when the patients have recurrences and may have bleeding. During surgery, it is key that we, whatever method you use, I use a chandelier to scleral depress and be, as you saw, to be able to laser the periphery very well. Others like to use a laser, and I use that all the time as well. I mean, many times as well. Use a scleral depression with a laser that is lighted, and then with the light of the laser, you can just do your peripheral laser as well. But make sure that you treat the periphery, so do a complete PRP so that you avoid the chances of recurrence of vitreous hemorrhage. And then the injection of intravitreal bevacizumab at the end of the case, I think helps decrease the chances of postoperative bleeding. Something else that I do is that I leave a little bit of gas even if I don't have a tear. If we all remember that the axiom of no tear, no error. However, if I had a patient that had significant bleeding, I still some active bleeding, and I do endodothermy, but I still have some areas that I'm not so sure if they will bleed or not. I may be close to the optic nerve, and they may bleed later. I'd like to give a little bit of, leave a little bit of SF6 and ask the patient to be face down to tamponade. And that really allows for a significant reduction on postoperative hemorrhage. I don't know what you do, Naresh.
No, I think that's exactly what we do, and I think you know that this technique, Stan Chang, years ago, he would use this similar technique that you do. He would also sometimes use viscodissection with the viscoelastic, which doesn't quite work as well as your technique. And I agree with you completely on using air. I think in general we use air on all of our small incision surgeries, but particularly in this type of case, I think it makes a lot of sense. This was fantastic. Can't thank you enough for joining us. And I know we're running out of time here. Prem, you want to say a few last words?
Yeah, no, it was fantastic. I mean, tour de force of research just showing for the residents and fellows and our faculty just how you develop an idea and how you bring it to fruition like this. And so thank you, Fernando, for sharing with us, and we will definitely have you back so we can see you in person, take you out for a nice dinner, and learn more from you. Thank you again.
Thank you so much, guys. It's been a pleasure. You know where to find me. Please email.
Have a great day. Take care.
Thank you.
Thanks.
All right, thank you.
You too.
Bye-bye.
Bye.